everyone. Once again, welcome to our Friday sessions. I think we are running a bit late, so we'll start off with our first case. I think it's from Pune. So I'll hand it over to the Pune team. Krishnapriya, if you're there, over to you.
Yes, sir. Good evening. This is a 2-year, 3-month-old male child. He was born, third born to non-consanguineous marriage. There are 2 healthy siblings, and it was a home vaginal delivery. He was AGA with cried immediately after birth. There is no relevant family history. The child was brought at 5 months of age to Bharti with suspected diagnosis of battered baby, where the child had a bulging AF, multiple ecchymotic patches and nodules over the body, spine, lower limbs. Severe pallor was there and high BP, poor GCS. CT and MRI was done, which showed hemorrhage, SDH on the left side. And on workup, PT was isolated. PT prolongation was there. Vitamin K was given for a few days since it was a home vaginal delivery. And FFP cover was also done, and barhole evacuation was done of the hemorrhage. The baby had a normal liver function. On coagulation profiling, mild factor 7 deficiency was detected, 28%, which is coming as mild only. And later, after the acute episode was treated, serial coagulation profile was done. For the first 3 months, he had a mild prolongation of PT with normal APTT. And by 6 months after the event, the PT also normalized.
Okay, so I think I have a set of images of that. So sorry for the slightly pixelated images. We don't have scan images, but these are from the films. So I think this is the first MRI done at 5 months of age on 24th October 2020. So I have a T2 axis and coronal axis, and you can appreciate that there is a significant left hemispheric subdural hematoma, or their subdural collection with fluid levels. Also slightly on the right side. But you can see that the subdural collection is causing significant mass effect on the ipsilateral hemisphere, causing subpensile herniation, also some uncal herniation out there. So predominant changes, also some subdurals around the facts on the contralateral side. But predominant changes are on the left hemisphere. Again, the coronal sequences better demonstrate the mass effect. You can see that the ventricles and the facts is herniating towards the contralateral side. So yeah, main changes were there. I couldn't appreciate any parenchymal abnormalities in terms of hematoma or ischemia on these T2 axials. But on the diffusion, you can see that I think possibly secondary to the mass effect, there is some degree of infarcts over there in the basifrontal regions along the posterior circulations or either side, and again in the frontal lobes. And these are the SGRE sequences, again better demonstrating the extraaxial corrections. Extraaxial hematomas, again, more on the left side, also along the falx, tentorium cerebelli, and some degree also along the posterior fossa and the dependent portions. And maybe some degree of subarachnoid hemorrhage over there in the left superior frontal lobes. But the main changes are the left hemispheric subdural collections with some degree of fluid levels and some septations in the frontal aspects. And then I think this was a follow-up scan. Is that right, Krishnapriya, or is it the same scan?
This is the same scan. The child also had retinal detachment due to choroidal hemorrhage during that time.
Okay, so left eye, as you can observe, especially on the image on the right, there is choroidal detachment on the left eye. Choroidal images over there, also the axial sequences. So initial findings over there, I cannot appreciate anything on the right side, but yeah.
Then once the PT was normal, by that time the child had developed a hemiparesis of the right side, and there was some weakness of the left side as well, and the child was close to fall off for the last 1.5 years, and the rest of the scans are done outside and only plates are available.
All right, I have a CT after that. So I think I've written presumably to look for calcifications. I'm not sure if that is the indication. Maybe they just want you to see the subdural collections, the status of subdural collections over there. So it is reduced in comparison to the October scans, but there is again persistent subdural collections or hematomas on the left hemisphere, especially in the frontal lobes. The parietal temporal, those mid and posterior aspects have almost significantly reduced. Slightly more increased on the right side. If you see the right frontal has slightly more subdural collection in comparison to the first scan. There is a degree of volume loss in the left side of the hemisphere. Some cortical, subcortical calcifications out there, bilateral hemispheres, but more on the left. Coming down into the axial sequences, lower down, again, you can appreciate the subdural collections. Again, more on the left side, again, degree of volume loss, meiosis and circumambulation on the left hemisphere. There is secondary dilatation of the lateral ventricles and calcifications predominantly along the subcortical cortical regions. Posterior fossa appears to be relatively preserved or normal in terms of in comparison to the supratentorial findings.
Good evening, Dr. Nihaal.
Yeah.
I just had one query on this scan, the
Sure.
last one. So the bleed, the effusion, or is it a bleed or a effusion?
It's a
on the
bleed
right
because
side?
it is not. It's a bleed. It's a bleed. Both are.
It's a
bleed.
bleed.
The
So
right
it's a
hand,
new
it's
bleed, right? It was not there in the previous one.
In October, it was there. You see over here on the SWS sequences, you see that there is some degree of blooming or there are darkish hypointensity changes.
Okay, okay.
Can you see the arrow pointing up?
Yeah, yeah, yes, yes.
Yeah, so it was there, but maybe it's like I'm not able to measure it, but maybe slightly more or in comparison to this in terms of thickness. But right side was there, definitely.
Oh, because we had that query that whether it was a new bleed or what. Maybe because of the volume loss, now it is much more visible.
Yeah.
Sure.
So then I think a month later, you got another CT scan done. Any procedures done in between from February to March? I think in 1 month interval.
No, no, not that we know of, sir.
Okay, so this
No, only burr hole evacuation was done at the first instance only in October 2020. After that, no further procedure has been done. These are just follow-up scans which were done because there was a assumed to be a new bleed in that second scan. That's why then they kept on doing. And because the the PTs were also prolonged for almost 6 months. That's why they were doing the scans outside. Yeah.
So in terms of the subdural collections, they have significantly improved in terms of the thickness. I mean, the right side is almost completely disappeared with some residual changes over there. But even the left side, the subdural collections in the frontal regions have significantly reduced. Persistent changes of volume loss are there on the predominantly on the left hemispheric regions and the calcifications. I think then. So from March to July, anything in the clinical aspect?
Clinically, nothing was there. They were looking for new bleeds, is what we are guessing. So we thought that there is a new bleed in just the scan, in the cerebellar region and right side.
Okay. So July, I think I have a coronal sequence. You can again appreciate volume loss there, the hemispheric meiosis and circumambulation. Subdurals, in terms of subdurals, nothing. Prominent subdural collections, but no hemorrhage or acute hemorrhagic changes. T1 sequences, again, they demonstrate the same changes as compared to the CT scan. Left hemispheric volume loss with meiosis and circumambulation. I cannot appreciate anything significant in terms of extra-axial collections, at least in comparison to the first and the second scans. And these are the GRE sequences. Again, possibly some signal dropout there may partially contributed by the burr holes in the left frontal region, but in terms of extra-axial collections, slight thin remnants, but nothing very significant is what I can appreciate on these scans. Posterior fossa cerebellum, which side were you saying? Should be right side?
Yeah, it's mentioned in the report that right side cerebellar hematoma is seen. Extra-axial.
No, I cannot see any hematomas. This is the phlovoid of the transverse sinus. This is not a bleed. No, I cannot appreciate any extra.
And this child actually had a left hemi and recently then started having a lot of faults. So we were not sure, like on examination, he's got a right-sided hemiparesis, but he has a spasticity which is there in the left lower limb as well. So I think that is
Slight left.
explained by the right ACA gliosis, right? Frontal.
Yeah. There is gliosis on the right side too, frontal region, also in the temporal parietal regions also. White matter is
Oh.
reduced, the left side more severely affected in comparison to the right side.
Sure.
Then I think we had one more scan in Jan 2023. Anything from July to Jan?
Clinically no change. The child has actually caught up on the milestones. By now, the child is almost 2 years of age, and he's
Okay.
even though left side is gone, he has speech, and milestones are there.
This report is of the same scan, I guess. Because they had mentioned no extracts of significant correction, but I'm not sure if this is of this scan, because it doesn't corroborate with the other sequences, this extraxal correction over there on the temporal lobes. I think this is possibly of the first scan. Because other sequences does not there and is not mentioned in the report.
In this scan, they have also mentioned new areas of gliosis on the right side.
Gliosis was there previously too. Maybe it
Yeah,
is more
that was in the
evident.
frontal.
Yeah.
But now they said even
Parietal.
periatrial and I think parietal, was it mentioned, Krishna?
Yeah, that was there.
There's a periatrial.
Okay, so it was there previously also.
Yeah, it was there previously also.
Because we could appreciate the frontal one.
So if you see on the, that's almost reaching up to the cortex there, and there's some signal changes, which is not some VR spaces changes, but surrounding that there is again some hyperintensities, and there is no clear lining between the ependymal margin and the hyperintensities. So there is some degree of white matter change over there in the parietal regions also. Also, if you appreciate the cortex subcortical regions,
that was a
hyperintensities.
Yeah, that was a major query, whether there are any new bleeds in the subsequent scans, new areas of gliosis, and how do we explain those calcifications?
Calcifications are, I
because
think, chronic
parenchymal
ischemic
bleeds were
dystrophy.
not there, no? That time?
No, it wasn't there.
So it is just because of
But-
the ischemia.
Yeah, it is ischemia. So I think this is not.
But
this
on
is
the
not
right
of the-
side,
Yeah.
the right side did not have any significant ischemia, right?
No, it had
left
the
side-
infarcts. This is what scan. So right side you can see the frontal region over there. Here, this area has infarcts over
Yeah,
there.
but the calcification is
Calcification is.
do you have that snap of
Yeah.
the calcification? Yeah.
Yeah, it is over here. Subcortical cortical regions, parietal lobes, bilaterally, more on the left. And also in the occipital regions.
And the right side, is it corresponding to the area of ischemia? Because the gliosis was not that visible at that time. So maybe it was still ischemic only. So that can explain. Okay.
Yeah, so the most recent scan has again changes, chronic changes with gliosis, encephalomania, and volume loss, but no acute extraxial corrections, no parenchymal hematomas, no acute abnormalities, no acute ischemias. Yeah. So yeah, these are the set of scans, and yeah, if you can summarize, Mr. Priya.
So this child initially had home birth, and vitamin K was probably not given. And by 5 months, the child presented with an acute plus subacute bleed (SDH) and a partial factor 7 deficiency. And FFP was given for almost 10 days, and still the PT was prolonged during that time. And a whole evacuation was done at 5 months of age. Then around 1 year of age, till then the PT was slightly prolonged, and by around 1 year of age, the PT normalized. And after that, when we have repeated, the coagulation profile is normal. And by this time, the child developed right hemiparesis, and left lower limb slight weakness is there, and his gait is as such. And on follow-up, scans were done suspecting bleeds, but clinically he did not have further deficits. And all the rest of the milestones he caught up. And now he is 2 year, 3 months. And now his main issue is that he has recurrent falls. Apart from the already weak limbs. Yeah, and EEG, he is on a single low dose of anti-epileptic, and EEG was showing a breach effect, left hemisphere attenuated background, and right few frontal discharges. He did not have any further seizures.
Okay, so he has seizures
So-
previously.
Yeah, so what was very atypical about this child was initially at 5 months, he was like considered to have a battered baby. And then even after giving vitamin K and FFP, the PT took almost 6 months to recover, to normalize. So though the factor 7 is not in that pathological range, 28% is supposed to be mild and not usually associated with such intracranial bleeds. So we are still going to again reevaluate the child because they were lost to follow up and now have come back. So we are going to again reevaluate the factor 7 levels and try to even look at other deficiencies like hypoproteinemia and all those things. So any other comments from, because our major concern was whether because there was mention of new bleeds and calcification. So we were thinking whether we are missing some syndrome, some kind of a vasculitic kind of a etiology here. So that were our main concerns. So any other comments from the faculty?
Was skeletal survey done, Dr.
Vasculitis would be very unusual since you have only in quotation marks affected one hemisphere. And the involvement of the initially healthy hemisphere is explained by the subfalcial herniation, where you get less perfusion of the frontal lobe on that side. So I think you have an initial bleed. You can still discuss whether this is due to the factor 7 deficiency, but all other things are kind of logical sequence. And I see no evidence for a syndrome and no evidence for a vasculopathy.
Sure. Thank you so much. Any other comments by anyone else? Okay, thank you very much.
All right. Thank you. Thanks, Reddy. All right, to our second case, Arushi, if you're there. Or Dr. Rashmi.
Dr. Arushi, you're
Yes,
there?
ma'am.
Ah,
Yes,
yes.
ma'am.
Yeah.
Arushi, go
Yes,
ahead.
so
Ah.
this was a 2-year, 5-month-old child who came to us with fever, generalized tonic-clonic seizure, and deviation of angle of mouth to the right side. The birth history was normal. She was a well-immunized child and developmentally normal up to 5 months of age. So she had a significant past history. At the age of 5 months, she had presented with fever, cold, and generalized tonic-clonic seizure, and she was investigated in a Pune hospital. Her first MRI there was showing left ICA, right ICA watershed territory infarcts. Her initial investigations there were hemoglobin was 9.5 and the peripheral smear was showing microcytic hypochromic anemia. Her B12 levels were normal, her homocysteine was normal, and her 2D echo was normal. She was started there on injection phenytoin, Gardneril, and Levera, and she was given nitroprusside and amlodipine to control her BP. And at the time of discharge, she was discharged on aspirin and anticonvulsants. Then she was again readmitted after 3 months, and her second
Okay,
MRI was.
Arushi, I'll just stop you there.
Yes.
I have these selected images. Is this of the first MRI in 2022? October 2022.
So first MRI was in September 2021.
Okay, September 21. Okay, I don't think I
Ah,
have the images for
yeah.
September 21. All right.
September
okay, go ahead.
2021.
Go ahead, Arushi.
Yes, sir. So the first MRI was showing this watershed territory
Okay.
infarcts. Yeah.
Okay. So bilateral infarcts, ICA and the right ACMC. Got it.
Yes, sir. She again her MRI was repeated on 14 September again. That was showing
Okay.
persistent diffuse large areas of acute infarcts that was involving the left caudate lentiform nucleus and cortex, corpus callosum, and the left cerebral hemisphere. This was a second MRI.
I don't have the second MRI. I have the October one in 2020.
Okay. That will be the third MRI you have, Dr. Nihaal.
Yes,
Okay,
sir.
so repeated
Yes.
ischemic events, recurrent ischemic events
No,
from
no.
past.
There was only one event, but I think they were
Okay.
following up the child with MRIs to see whether there was any progression or whether there was any vasculitis. So the first 3 MRIs were done in Pune only.
Okay. So the first and second MRI, there's no new ischemic change, just like chronic changes. Is that right? Or the first MRI?
Yeah. First MRI, I'll tell you. First MRI was on 11th of September. They
Yeah,
had
okay.
left ICA, right ACA, MCA,
Yeah.
watershed territory infarcts.
Yeah.
Then they repeated the MRI within 3 days in the hospital itself in Pune.
Okay. Okay.
And the repeat MRI showed persistent diffuse large areas of acute infarcts involving left caudate, lenticular nucleus, cortex, corpus callosum, and all that.
Yeah, I think within 3 days that is expected. So.
Within 3 days, it has gone a lot more.
Yeah.
So then
Okay.
they, and the baby needed a lot of anticonvulsants, as Dr. Arushi mentioned, to control the seizures and everything. So they followed up the baby to see why this baby has had a stroke, and then they repeated the MRI again in October. January 22, they repeated an MRI in October 2022.
Yes, ma'am.
Dr. Kavita, I think it may be your hospital. I'm not sure.
Ma'am,
you know which hospital?
KM, ma'am. KM, Pune.
KM Pune. Okay. So it's not your
Yes.
hospital then.
All
Yeah.
right. So this is the October 2022 scan. I don't have the parenchymal, the main images. These are just the vascular images. I think they have an angio and a vessel wall imaging done. As you can see, there is some segmental narrowing, mid-terminal narrowing of the ICAs on both sides, reduced caliber of the MCAs, especially the left MCA, also the ACAs, proximal ACAs. So these are the arrows pointing out at the various areas of stenosis or narrowing. I think what they've tried to elucidate on the vessel wall imaging is, I think, contrast uptake. But as you can see that this is a lumen and there's no significant, at least uptake of contrast on the vessel wall imaging. There is some degree of irregularity, but I do not see any contrast enhancement if you compare that with the pituitary stalk, which is usually an indirect marker for enhancement of the vessel wall changes. So at least on these axial images, I do not appreciate any significant wall enhancement over there. Even this areas, I think this is around the bend of the arteries. So again, I'm not very sure if it's really significant enhancement of vessel wall thickening over there. So these are the selected images I have of October 2022. And then there is one in November. Anything in between, Dr. Arushi or Dr. Rashmi, from October to November?
No, October and January. Yeah, that's right. October 2022.
Sorry, January. Yeah, sorry.
January 2022. So that was one before October. Yeah.
All right. So just a routine follow-up scan. No.
Yeah, routine follow-up scan. No, the child did not have any other event. It was a routine follow-up scan.
Okay.
I think they were suspecting progressive vasculitis in Pune. So that's why they were doing these close follow-up scans.
All right. Again, narrowing of the arteries of circle of Willis or there, the ICAs, the MCAs. Now you have tortuosity of the vessels, especially spiral vessels. Some collateral formations, especially along the mid segments over there. Subdurals, we don't have previous images. So I think these are the chronic changes in the parenchyma and also subdural collections, extraction collections in the left hemisphere. So that is what we have from January. I think we have a recent scan which was done a month back. So in between, Arushi, if you just want to summarize the other clinical details.
Yes, sir. So when the child came to us on examination, tone was slightly increased, reflexes were brisk at knees, and she had a right side hemiparesis. We investigated her CBC, CRP was normal, urine routine was showing certain pulses, and in view of fever, we started her on ceftriaxone. But on day 2 of admission, she had another episode of seizure, so we started on sodium valproate. We even did a CSF analysis, which was normal, sir. We even did her whole exome sequencing, which came out to be negative then.
So this admission was predominantly an illness-triggered seizures for which we gave treatment. We didn't think there was any new deficit in this particular admission in our hospital. But then father told me that because they had so many MRIs, because they were considering progressive vasculitis and they were discussed in Pune and Mumbai and all that. So, and there was another MRI planned for the child to know the exact diagnosis of the child. So in this admission, there was no deterioration in her neurology from before. Whatever she had from before was the same, and these seizures were probably secondary to her illness-related seizures. And now she's not had any seizures after this admission. This, I think this was in October or November 2022. Is it right? No, sorry, March 2023, 6 months back.
All right. Then she had a follow-up scan last month, a couple of weeks back inside.
Yeah.
And again, on diffusion, no acute abnormalities, changes of old ischemic changes in the more in the left hemisphere compared to right. Again, better demonstrated in the T2A sequences. I think the subdural collection, which was seen in the prior scan, is now significantly reduced. These are all subarachnoid or subarachnoid prominence over there. Again, well-hidden degeneration with encephalomagnetic changes going up to the brainstem on the left side. In terms of the angiography, and so you can appreciate that there is again some degree of collateralization in this around the circle of Willis. Again, but you have some collateralization along the FARCs over there, and possibly some ventricular arteries are prominent, especially on the right side. And then we did a vessel wall imaging. Just again, we could not find any significant enhancement of the vessel wall, possibly a focal area over there, but other than that, I could not appreciate any other areas of significant vessel wall enhancement. Contrast was done, again, expected changes of the prominent vessels. You can again appreciate the collaterals forming over there in the right frontal region along the FARCs and along the circle of Willis and independent class cistern, amnion cisterns, pleural cisterns. So yeah, these are the main changes. Some dural enhancement, again, that is expected. What the SWI sequences found, we found that again, you have these multiple tortuous vessels, especially in the cortical, subcortical regions on the right side, in the temporal regions on both sides, and again, you can see in the cisternal spaces, again, some prominence and tortuosity out there. So these were the findings. I think now the question was whether this fits into a Moya-Moya type pattern, or as termed in the previous discussion, was it progressive vasculitis? So I was not sure what is progressive vasculitis in terms of the etiology or in terms of the management. So if anyone wants to chime in with their thoughts, that would be helpful.
Yeah, so basically progressive vasculitis, I'm thinking that they're thinking of a small vessel vasculitis, which will need some immune modulation and all to prevent it from progressing. So large vessel, medial vessel, small vessel vasculitis. I think that is what they were thinking. For genetic etiology, we did a whole exome and mitochondria. So there is no genetic etiology, it's negative. So the question is either whether it is a simple focal cerebral arteriopathy secondary to iron deficiency anemia, which was there at 5 months of age. And then these are all the residual changes, or whether there is Moya-Moya, or whether there is progressive vasculitis. So these were our questions.
At least in terms of imaging, we did not find itis, vasculitis on the vessel wall imaging.
Yeah, I don't think vessel wall imaging was done in the previous scans. So
yeah, at least the one in October over here in 2022. Might be too late, I guess, but would that form collaterals? I'm not sure. Vasculitis. Dr. Lokesh may have some experience. Yeah, if he wants to talk about Dr. Vijay.
Nihaal, that SWA shows the veins very, very prominent. Most likely, this child would have received some oxygen during MRI, but still it was
under
very,
anesthesia. Yeah.
So whether any chance of sickling positivity, because you see what was the hemoglobin level of that child?
Hemoglobin, the baby was anemic first time round.
Okay.
Yes.
Recent, what was the recent one, Dr. Arishi?
1 minute. HB was 9.5, ma'am, here.
Okay, so for a 9.5 and under anesthesia, these veins are little more deoxygenated to me.
Yeah.
And I don't know whether there are micro bleeds also there. So whether it's a secondary Moya-Moya of a sickling or some other disease, I was thinking.
Secondary Moya-Moya, secondary to?
Sickle cell or any of these.
Sickle cell anemia.
Yeah.
We have not done hemoglobinopathy as far as I can see.
Sir, but the HB electrophoresis was also negative, normal here.
It's done, HB electrophoresis?
Yeah, in the Pune hospital, they had done, sir, it was normal, HB electrophoresis.
Oh, okay. Okay.
So
there is no
I just had a
cyanotic,
question.
no cyanotic heart disease also.
No, sir. Echo was also normal, sir.
Okay, okay. Thank you.
So I just had a question, like if it's a systemic disorder like sickle cell and all, won't the changes will be bilateral, almost symmetric? Here there is quite a lot of asymmetry if we see here on the current image being displayed.
But left hemisphere is almost gone. That's why there is no oxygen extraction. The other side, there is
Oh, okay. Okay, fine.
the veins are very prominent. Why deoxygenated? A child under with anemia as well as the child having under oxygen should not show any veins. But even this, these
Okay, can
veins
you
are very,
point
very.
out where are the veins, Dr. Nihaal? Which the images
These,
showing the veins?
all the prominent signals over there, some around particular regions.
So they are looking
see.
prominent on one side because the other side has hardly any brain parenchyma. And what about the oxygen being given during the MRI? How does it affect that? Hello, am I audible?
Oh, yes,
Can you hear
you're
me?
audible.
Nihaal, it might be useful to explain the SWI a little more. I don't think we are not seeing veins because there is no brain on the left side, isn't it?
I think so. So the veins will become prominent only when there is oxygen extraction happening. And because there is no parenchyma, there is no oxygen extraction happening.
Yeah, so something new concept for us. That's why we just wanted a little more explanation. Yeah.
No, and these veins, can we zoom that image? SWA. Are these veins normal? Are there any subcortical dot-like structures other than veins? So left side also you can see subcortical dot-like hemorrhagic structures. So
what would they imply?
No, whether this is a vasculitic process can produce that, but I still can't explain why that veins are very, very prominent on because deoxygenated hemoglobin is there. Because of ischemia, I can explain to little bit because supraclinoid ICA narrowing is there. But still it is very difficult to see such veins.
Does it not just imply slow flow? Or it is sluggish
Yes,
flow
slow
in the
flow
circulation?
and increased oxygen extraction of that side because the flow is limited. Whatever oxygen is coming to that, it is getting extracted. That's why you see a lot of deoxyhemoglobin in the venous side. But in addition to the veins, if you zoom that image, what I can see on my mobile is that multiple irregular dots are there.
So are they microbleeds?
I'm not sure from this.
Okay. Thank you.
So what would they imply? They would imply that the baby has some sort of hemoglobinopathy, is it?
No, that's why, because of, corroborating all these things, I thought of sickle cell, which can produce moya plus venous abnormality plus microbleeds. So since it is not there, I don't know what else I can think of.
So it cannot be like just a simple focal cerebral arteriopathy in the beginning, which has caused the damage. So is something more to it?
But bilaterally it is there. Bilateral supraclinoid ICA is there. That is very bad. It is like a moya pattern. And there were collaterals, and then collaterals disappeared. Then there is infarct or a...
So are those small microbleeds can also be explained by the fragile, the puff and all what you're getting because of the collaterals, and the same can have those microbleeds? So they are fragile?
I'm not very sure whether we are only concerned about the proximal vessels, whether it's a distal vasculopathy also associated, I don't know.
Okay, thank you.
So this is secondary moya, no? Secondary to the narrowing, rather than the primary moya, Dr. Nihaal?
No, I think it is secondary.
No, narrowing was there. Narrowing was there, but it's secondary to something. You don't know what that something is. related
No,
to
whether
blood.
talking about a Moyamaya disease or a syndrome, that is the question.
Yeah,
So
yeah.
it's a symptom. Something has to be underlying.
Yeah.
Anyway, this is a Moyamaya pattern with actually
Yeah.
a very little collaterals now. That's why the left side is completely infarcted early. What is the underlying cause? It is difficult to explain from these images alone. Nihaal, do you think that it is just a 3T? Do you see veins just like this in neonates under anesthesia?
No, we don't see this. This is slightly more slightly more attenuated than normally seen. I think, but the
Would
main
you
question
consider
was
a
first.
biopsy to? Sorry.
Yeah, Dr. Sorry, go ahead.
Yeah, no, I
Yeah.
was just suggesting if we are not having a diagnosis, Dr. Rashmi,
Yeah.
would it be possible to do at least a meningeal biopsy and find out what? Maybe it will give you an answer that whether there is a vasculitis going on or just.
Oh, just a
And
simple
maybe that
meningeal
tissue you can
artery
send
biopsy.
for exome studies also, because sometimes somatic mutations you may not get anything in the peripheral blood.
Exome we've done. Whole exome and mitochondrial is negative.
No, from that biopsy specimen.
Oh, from the biopsy specimen. Okay, fine.
Yeah.
I'll check with our. So this would be a very easy thing to do. Is it just from the outside meninges only you can take an artery and send it off?
Yeah, I mean, we'll have to study what exactly, which part to take.
Yeah.
Has anyone
thing is-
experience? Has anyone experience with the investigation of such a biopsy? I think this could be very non-specific.
Yeah, I was just going to ask that, sir. Thanks.
Yeah.
So my next question was, do we operate?
So, but
Even the Moyamaya,
then
do you
you-
wait for another stroke, or so the child is just being followed up on imaging? Because of the narrowing and ongoing process, there's always a chance of a repeat stroke again.
So would you consider doing some sort of
revascularization?
vascular, those procedures where they do
Yeah,
put the temporal artery inside and all that?
Yeah.
Yeah.
Procedures.
Yeah.
Now you have only one hemisphere. Yeah.
Only one hemisphere. Yeah. When I spoke to the neurosurgeon, they were not very keen to do it, but I think this scan they haven't seen, so I will ask them again. You said that Dr. Lokesh has experience with this sort of
I mean, yeah, we do a large load, but I don't think we have location on board. Dr. Lokesh, Dr. Subodhi, around 30 to 40 Moyamayas in last 2 to 3 years.
Oh, okay. They take the temporal artery inside and
Hello?
just attach it to the meninges.
No, usually we do indirect, this one, EDAMS is usually done. So indirect, this one only we generally do. In the bigger children, we do the direct anastomosis.
Okay. So indirect
So
is just
I think, yeah, encephaloduromyosis and angiosis, they have very good results, and it preserves the parenchyma quite well. And even after the first insult, we go ahead with the revascularization.
Okay, fine. I'll speak to the neurosurgeon about this.
Can I jump in? I wonder whether
Yes.
you need a proper angiography to see exactly the situation of the vessels before you consider anastomosis. And maybe Dr. Mankat has greatest experience from Great Ormond Street. What does he think about Moya? If he's still here.
Yeah, I'm still here. I just jumped into this case midway. The patient needs a DSA, should have been done months ago now. So is anyone saying no to doing a DSA?
No, nobody said no. They're willing to do everything you ask them to do.
All right, so we do need a DSA then, I think, at baseline. It is the fairest contribution to this case right now, because if you think you're planning a revascularization, you need to know what the reserves are, which I don't think these techniques are giving to you at this point in time. I was in the background trying to find a companion case to show you all today, because I know you have less cases, but Pritika, my colleague, is going to send me the details, and it's a slightly different angle, but a useful case still to understand SWI and perfusion and things like that. And Bijoy being here in the meeting today, it might help us to understand our own case a bit better. They're not straightforward. But moving forwards, I think a DSA is required if you want any more done for this kid. I believe those small flecks, by the way, Bijoy, are little microhemorrhages, and they're on both sides, not just on the left, in the background of all the pronounced vascularity that you're seeing on the contralateral side. And it would be completely within the spectrum of a vasculitic process. I guess you have excluded sickle cell, but there might be many other possibilities. And I think some suggestions did come up for even entities like RNF213, for instance. I think they're all relevant to be screened if possible. And I agree.
The whole exome was done. We didn't get it.
Whole exome in mitochondrial was negative.
It was, but I don't think all these mutations could be picked up on whole exomes.
Okay. I can ask them to look at the specific mutation, the lab RNF2L3, is it?
And definitely worth looking at the kidneys as well for any systemic changes, whether they have any hypertension, for instance, that might be relevant, renal artery stenosis.
Ring finger protein 213, Dr. Manoj Nayak says.
You can ask them to look for the Moya-Moya syndromic changes. They should have a panel. RNF213 is included in that. So.
Nihaal, to this, is this a staggered picture? Are they having small infarcts previously and then suddenly big ones, or is it a one-off event?
It's only one-off event. It's just a one-off event.
From 2 years back, and this is the most recent one.
Okay. And we are fairly convinced about narrowing on the right side. It's not related to velocities.
No, yeah, we are fairly convinced of that.
Show me.
You want the initial ones? Yeah. So this is the most recent one we have. So you have narrowing over here. And the second image over here. The ICA is narrowed. ICA is narrowed.
So at the moment, you haven't been able to demonstrate progressive narrowing, right? Or progressive vasculopathy, occlusive vasculopathy. Is it a one-off, or do you have multiple time points?
Yeah, so this is in October 2022. Then in January, you have again narrowing with some collateralization from over there, which was not there in the previous scan.
But the collateralization is happening elsewhere, isn't it? It's not basal.
No, it's not basal at this point. But there is again, narrowing is still persistent. Slightly more, I guess.
So it's not typical for Moya-Moya, this.
This is the most recent one. Still,
so is that narrowing increasing? Is it narrowing in other places as well?
That we can only answer if we had all the base images, but if Nihaal has them, he can answer that question. From what I see, I don't see a progressive occlusive vasculopathy unless you all have seen it on static images.
No, there were 2 more images initially, which I don't have.
So have you seen a progressive occlusive vasculopathy?
I've seen static vasculopathy.
So it's an open case, I think. And if I can find our own case, which is a tumor-orientated case, I will definitely share it with you all at the end of this meeting, because I needed some advice on that as well.
Okay. All right.
Okay. So Nihaal, this DSA will be able to do it?
No, that's not at a lab cath lab. The intervention people do it.
So intervention radiology will have to do it.
Yeah.
Okay, fine. Yeah. Okay, I'll check with the neurosurgeons about it.
Sure.
But even if it was a progressive vasculitis, you wouldn't consider immune modulation and things like that, right? But it's not a progressive vasculitis is what we've concluded.
I would start with the DSA and then maybe take it from there.
Okay, I'll speak to the neurosurgeons and
neuro intervention.
The neuro intervention people, is it? Okay.
Yeah.
Have you all imaged the neck? Has the neck been imaged?
Neck, I don't know. Nihaal, Dr. Nihaal, neck.
No, we did the brain. Neck was done previously, which was normal.
Okay.
In January.
Okay.
Yeah.
All right. Yeah, I think we need to move to our next case. We only need
okay, thank you very much, everybody. Thanks, everyone.
Divyashi, if you're there. Or Dr. Rashmi.
Dr. Divyashi? She's there.
Yes, ma'am. Hello.
Yeah.
So we had a 2-year, 2-month-old child by name Hita.
Name is not required. Go ahead.
Yeah. Came with the complaints of generalized tonic-clonic seizures lasting for 70 minutes. So child had 3 episodes of generalized tonic-clonic seizures lasting for approximately 70 minutes with no regain of consciousness in between. First 2 episodes responded to midazolam nasal spray, but third episode did not respond to injection lorazepam, Levipil, phospheniton, and seizures stopped with the injection propofol. And there is no history of fever, rashes. And coming for the past history, first episode of febrile seizure was there in the July 2022. Total duration was 4 hours, presumed to be due to COVID-19. And child was on Levipil from then, 20 mg per kg per day. And MRI brain done at 1 year of age showed partial agenesis with severe thinning of genu, body, isthmus, and splenium of corpus callosum.
I'll show the MRI. Okay, so we have only one MRI. I don't have the sagittal sequence. I don't have a T2 axial or coronal or sag. I have only a flare axial, and on the flare axial, you can appreciate that there is some degree of cortical volume reduction in the frontal lobes. But coming down to the central regions of the brain, some dysplastic lateral ventricles out there, dysplastic basal ganglia, dysmorphic basal ganglia out there. I cannot appreciate the anterior limbs for a 1-year-old, even on the flare sequences, it should be evident, and it's that because of the dysmorphic basal ganglia, the ventricles also abnormally oriented and dysplastic. Even coming down, lower down, the brainstem appears to be hypoplastic. I don't have a sagittal sequence, but you can appreciate the reduced volume of the brainstem. No cortical malformations per se on these flare sequences, only the degree of volume loss and these central changes predominantly affecting the basal ganglia. I think even the thalami are slightly asymmetrical. The right side thalami is slightly reduced in volume compared to the left. So central changes predominantly in the suprainfratemporal brain. No hemocytin products, no calcification on the GRE sequences, no diffusion changes. I had an SW sequence, which I tried to just reformat into a sagittal sequence to better appreciate. If you can see clearly, if you can see the brainstem structures and the cerebellar structures, you can see there's some degree of pontocerebellar hypoplasia. Corpus callosum also, if this is the corpus callosum, then it is agenetic or severely hypoplastic. So based on these imaging findings, I think it was commented to be as sequelae of hypoxia. Is that right, Dr. Rashmi?
Oh, yes, that's right. They had commented as this is a sequel of HIE. However,
okay, so these are the various patterns of HIE. Again, doesn't fit into any of them. Based on the images,
there is no history of HIE at all. So yeah.
Yeah, based on the images, the closest match was the tupinopathy given the central changes, which can be also have corpus callosum abnormalities and brainstem separa abnormalities. So at least that is what we are thinking in terms of imaging and open the case.
Because they were very clear that there was no history of any perinatal event. So
yeah, even if there is history, it doesn't typically look like this.
So this is looking like tubulinopathy. We had one more child that day we are discussing.
Yeah.
Okay, I will speak to them about genetic testing.
Nihaal, any chance of it being a ADGRG one?
ADGRG cobblestone is not there.
That right basal ganglia, is it fused? I'm not very sure about that.
It looks to be on at least so yeah, you see, I cannot even the left one, I cannot see the.
Okay. Can you see the SW in this case for just
yeah.
See the SW, it will be usually like this under anesthesia. You see only these very bright veins, no? It's because of oxygenation.
Yeah.
You don't see any veins at all.
Yeah. Just to add, there are different centers, but obviously, yeah, you can see the difference.
So hardly any veins in this one, no? No.
Yeah, normally we usually don't see that. Dark veins.
There is an asymmetry of the two hemispheres, Nihaal. From static pictures, don't you agree that the right frontal lobe and the opercular region is underdeveloped? And I'm trying to understand what is happening close to the septum. Is that deficiency of the falx or some interdigitation going on? There is a difference of the two sides. I don't think it's a tubulinopathy at all.
There are many points in favor of a tubulinopathy case. This is a genetic condition. abnormal basal ganglia, abnormal corpus callosum, abnormal brainstem, abnormal cerebellum.
There is actually not much white matter either. If you look at the left side, the ventricular interface is pretty much touching the cortex on that fourth picture on the top. So first, there's an asymmetry between the two hemispheres. There is reduction of the white matter volume, particularly you can see that ventricle which is dilated and it's got flailed margins. And then this right frontal relative underdevelopment compared to the rest of the brain. I don't know if they're overall microcephalic or not. This is not the typical morphology of a dysmorphic basal ganglia that we encounter with tubulopathies, and there is an asymmetry even in the basal ganglia thalamic level. You will agree, at least on the pictures that you give. Are you picking up an obvious asymmetry and dysplasia of the brainstem? Because I don't see.
Not on these pictures.
And I don't know about the corpus callosum if you have a sagittal or not, but
No, I don't. No, I don't have a sagittal. But
Yeah,
I just reformatted the excellence.
it's a bit of an open case.
But would you agree it's not hypoxia related?
They might
Absolutely.
have hit as for hypoxia cannot be excluded given the fact that the white matter volume is overall so
Yeah, but,
reduced.
no, but there was no history of a perinatal event.
If there is no history, that's fine, because I thought we had a history.
No, the MRI was reported as hypoxic injury, even though there was no history.
But is there any peripheral neuropathy with this case?
We haven't done a nerve conduction study.
No, but clinic.
But like I said, the child is also got asymmetric tone. So she prefers one hand, and she's got stiffer on the left side, I think the parents said. So
There's a difference on the two hemispheres within the brain. And whether this could even be a post-encephalitic phenomenon from that status epilepticus that you talk about, we will have to keep an open mind. But things that look like where the white matter is reduced and there is issues like this, we had encountered with a set of TBCKs as well, but they have peripheral neuropathy, they have respiratory difficulties. So I don't know whether radiology can actually give you a steer on which gene in this case, in other words.
Can we come back to that case when Dr. Rashmi has the genetic result?
yeah, we had a discussion case in
To
this
learn,
meeting.
because it's still obviously somehow open.
Yeah. I think, Dr. Nihal, we had discussed a case with tubulopathy, you had said in this meeting, and the genetic result came back as positive.
Yeah, that maybe have a different imaging picture. I'm not can't recollect the exact images, but I think we are sending the child for some certificate result.
Yeah, this one I can ask the parents to do. I was just thinking the corpus callosum in this case is completely almost absent, no? You would not get that much of an absent corpus callosum in HIE, would you? I thought it'll just be thinned out. Here it is like so much absent that the ventricles have lost their shape.
I wouldn't comment that because we don't have a true T2 SAG or T1 SAG. So before, because the report itself said HIE changes without an XI event, so we can't rely on.
The child woke up during the images, so that's why the center couldn't do, because I was in touch with the doctor at St. John's where this was done.
But at least over here I can see it's relatively very thinned out. So yeah, if you get a result, just get back to us.
Yeah, sure. I will update you once we get the result. Thank you so much. Thank you very much.
The pons small on that picture you just showed on the last one?
Yeah, the pons is small. Cerebellum is also small.
Yeah. So small cerebellum, small pons.
But even before the first status, they had a developmental delay. So
no, that's okay. It is still genetic, but I don't know whether we can put all our money in tubulopathies. Though when we say tubulopathy, all these genes do interact with the microtubules in some way or the other. But Nihaal will agree that it's not a barn door 2x2A, 2B, and one of those.
No, I never subcategorize them. So yeah, it's just that general. All right, Dr. Rashmi, get back to us if you have a result.
okay. Yeah, thank you so much. Thank you very much, everyone.
Anas, are you there?
Good evening, sir. Yes. Yes.
Go ahead.
Yeah. So this is a 5-year-old, 6-month-old male child, presented to us with history of fever for 7 days. He had vomiting on the first day of illness. He was admitted local hospital, treated for the fever. On 7th day of the illness, he developed some altered sensorium and a flurry of seizures, for which he required intubation at the referral center. Child was referred to us. When we saw the child on the day of admission, that was day 7 of illness. On examination, he had spasticity and clonus, ankle clonus. So we got a CT at the admission itself, and it was reported normal. We got an EEG done for this child to see the electrophysiology, electrographical activity. EEG showed diffuse slowing. So next day we had done an LP to rule out any meningoencephalitis. CSF was normal, acellular. And so after this, we were considering the possibility of demyelinating a disorder as well, and had started steroids. And meanwhile, we had sent for serum MOG and NMO.
When did you do the MRI, man?
Yeah, MRI was done
before sending serum MOG or after,
yes, after the MRI.
Okay, so that has to be in timeline.
Yeah.
All right. So yeah, we did an MRI. I think 7 days into illness. Is that right, Anas?
9th day into illness.
9th day. Okay. And how many days after the extubation?
The child was extubated just after doing the MRI.
Okay. After the MRI. Okay.
And how was the
All right.
child clinically after, at the time of the MRI or just after the extubation?
Yeah, child was hemodynamically stable. He required ionotropes, but no eye fixation, no eye opening was there, but no fixation or tracking.
And what, did he have a movement disorder? Did he have seizures? Anything? Was he in intensive care?
At our center, he did not have any seizures. He opened his eye on day 2, and then there was no motor response. Just only extensor posturing was there. And then by the end of day 3, we had day 2, we had some rigidity clinically. There's no movement disorder, no seizures at our center. Only encephalopathy.
No, the reason I'm saying is particularly with diagnosis, it's really important to correlate the child's clinical state with the MRI to try to find out the underlying etiology.
At the time of MRI, a child was encephalopathic. The eye opening was there, but no abnormal movements as such.
So this would be much more severe for what you would expect for this type of imaging with MOG, if that makes sense.
Yes, ma'am. Yes.
Yeah.
The MRI was the initial CT was normal, and the MRI was disproportionate to the clinical finding. Only he had some rigidity. That's it.
All right. So the MRI, we have flare on top and some particular hypertense changes in the frontal lobes, also in the parietal lobes out there. But the main changes on the deep brain nuclei, the bilateral dorsal striatum are demonstrating these confluent abnormalities. The right is slightly more edematous compared to the left. Again, the median thalamic nuclei, the posterior thalamic nuclei demonstrate hypertense changes. Also, mammary bodies also demonstrated some degree of hyperintensity on the flare sequences. The right temporal lobe also was slightly more hyperintense in terms of particle subcortical regions. Posterior fossa structures, brainstem was relatively spared. In terms of signal changes, again, the T2 sequences, similar changes in the frontal lobes, the particle regions, subcortical regions had some degree of hyperintensities, and T2 changes were similar to what we've seen on the flare sequences. On the diffusion, only the right mid and posterior preterminal changes and the capsular findings had these areas restricted diffusion, whereas the other abnormalities not demonstrate any areas of restricted diffusion on the diffusion changes. No prominent signal voids or signal artifacts on the SWI sequences in the deep brain nuclei. The corpus callosum slightly thinned out, but other than that, again, some cortical volume reduction and possibly some degree of hyperintensity around cervical cord. We didn't do an axial sequence, but yeah, these were the main findings. And then we thought of metabolic and, as Anas mentioned, autoimmune inflammatory disorders, biotin time and responsive disorders. So something which was odd for Leigh syndrome was the diffusion pattern, which usually is more symmetrical, not always, but yeah, usually it is, which was not there in our case. Child did not have any pharyngitis. Pandas also was kind of excluded, but we'll raise these possibilities on the after the imaging, and as Anas has pointed out, CSF viral panel was negative, but yeah, Anas, over to you.
Yeah, so the CSF viral panel was negative. So as the viral panel was negative, we're still not sure about the possibility, but considering the day deterioration on day 7, we were considering a para-infectious process as well. Based on the, at least at that time, before the MRI, he had some clinical findings like rigidity. So we're suspecting some basal ganglion involvement, but MOG was not on the, not higher up on the radar, but we had sent it anyway just to see if it fits, because it's a treatable thing. So we got the MOG back 3 days after the MRI, and which showed it was very strongly positive and 1 stent dilution. And we also had some CSF sample. We had sent the CSF as well for MOG. Meanwhile, clinically, the child showed some improvement after the extubation. He maintained with room air oxygenation. His eye fixing tracking improved. His sensorium improved. He started to recognize his parents. So currently the child is discharged. He was discharged just today. So currently there's no vocalization. He has some dystonias and some choreiform movement. This asymmetry of the clinical signs more on the left side. Currently he is crying well, still requiring NG tube feedings. So only thing is the clinical presentation was, the MOG, we're not expecting MOG to be positive, but this was a eye opener for us in a.
Other panels were sent, I think, Anas, to in Kochi, I think location mentioned. Other autoimmune panels were also covered. Better locations there, I think we have sent it to Kochi for other antibodies. I think rest of them came out of it.
I think you need to be a bit careful with when the clinical picture is not, because this is a bit atypical. We don't, even if you think clinically, I'm not saying this is not definitely not MOG, but I'm just saying it is definitely atypical. And with these fixed cells based assays, I recently had a patient, Kishan, I think probably is going to be mitochondrial, that tested positive on that, and then I sent for the live cell, and it was negative. Or did you even send another sample? Is it worth? Because I think particularly with some mitochondrial, you can get some, which is high on the differential here, mitochondrial. You can, and we saw it also with the NMDA 10 years ago. That we had NMDA antibodies in mitochondrial disorder. I don't know if it's the damage that caused this antibody creation or something, but I think we just need to be careful to differentiate between primary and secondary.
You have sent
CSF. Dr. Yeah, the CSF MOG antibodies were also positive, and they tested for other basal ganglia antibody studies, and that was negative. So they are trying to do other testings as well.
Anti-basal ganglia antibody we shouldn't be testing anymore. It's
in the sense, whatever.
D2, also D2 antibodies. So did he get any immunosuppression, this kid? So what's, because it just that the clinical state of this child is very atypical.
Yes, absolutely. That is the reason why we are trying to discuss here whether we need to further immunomodulate. He has received
I think
steroids.
maybe plexing him, you probably have, it's probably the safest option to do something like plasma exchange, because even if this is in the context of a mitochondrial, I don't know, that's what I would do if I had any doubt. And the child is clinically still quite symptomatic, no?
Sensorium is quite better. He's recognizing his purposive movements are much better.
He's not walking.
He is walking with support, not walking independently, walking with support, and neck control is better. Fine motor movements are getting better. So sensorium is almost normal, but not speaking at this point in time. But understanding is good.
And he is on steroids or no more on steroids?
He is on steroids. He is on steroids. Maintenance steroids.
And do you feel that the steroids have done anything?
Yes, absolutely. Both IVIG and steroids were given. And the initial period when we are not sure, he had received, I think, tocilizumab as well, isn't it?
Tocilizumab was considered, but we had not given it.
Okay.
Not given. Okay. Yeah.
IL-6 was elevated, but we had decided to wait and see on the
How elevated?
Yeah. I think it was 43 or so. 43. Cutoff is 6.
And your upper limit is how much?
6.
Okay, so very elevated. If the Can I just ask the radiologist, because what I'm just wondering now is whether this was like a cortical encephalitis, which would explain the severe presentation that we sometimes see in these kids that they go to intensive care. And do we think the basal ganglia injury could be secondary to the sweat to whatever disease process was happening?
From my perspective, Yale, I think it's still within allowances for MOG, all of it.
Even those basal ganglia changes, I'm talking about the dystonia would be a bit out of character. So even if we see basal ganglia changes in the context of MOG, like the boy we have on the ward today, they don't normally have such a kind of a movement disorder and motor problem so severely from the brain phenotype. So that's the bit that is a bit atypical for me.
But some thalamic lesions as well here.
No. I mean, I think it's whether this could have been a cortical MOG, like some of the one that we've seen, and he got a second hit from either hypoxia or...
No, not the typical features for hypoxia here, but the cortical changes are also obvious, right? Nihaal, I think you showed them.
Yeah, they are.
Okay. Because that would change, because if we think this is a cortical, like a more of a cortical MOG phenotype, which would explain why it's so severe, then one would escalate with treatment.
And is it definitely?
And I think you have two options. I think, plasma exchange is one option, and also an anti-IL-6 is not a bad option if you have the raised IL-6. It's kind of seemed to work in some of these cases. How easy is it to get tocilizumab?
We can get it, ma'am. Only cost is the only issue. We have the availability.
And plasma exchange would be cheaper?
Tocilizumab would be cheaper in the grand scheme of things, like considering inpatient stay and ICU stay.
Because I think both these options would be very reasonable if we feel that and I was also on the phone halfway through it. For me, just that the severity seemed a bit out of character, but sometimes we've seen with some of the cortical one, particularly when again the anti-IL-6 has been raised, which I think is, I don't know, we've seen it in the very severe cases. Tocilizumab has helped, and I think Brenda Banwell published 2 cases of MOG corticoencephalitis that responded to tocilizumab. Bear in mind, both these cases had steroids, Plex, IVIG, and a craniotomy all at the same time. But I think my feeling is that if you have some biomarker suggestion that the IL-6 is high, then that could be quite targeted. And it doesn't mean that you have to continue long term. You can give it for a couple of months and see.
Yeah, Anas, noted. The only question was the whole exome was sent and was
whole exome was sent and
was held back.
Kept it.
So
yeah, it was held back based on the CSF. I mean the MOG and serum and MOG. The child is improving, but that's the main query. Should we repeat IL-6? Would it help? Because IL-6 is beyond day 1 of admission. At that time,
yeah, you could. I mean, I guess what you could do. I mean, also, as I said, I think also the fact that if also Kish feel this is very much of a MOG flavor and it's positive in the serum and the CSF, so it's hard to ignore. So the child kind of now earned himself some more treatment. Even if there's an underlying genetic thing, like I feel it's hard to ignore it because this is a treatable condition, as you said. So based on these facts, I think you should escalate to something, and I would be guided by what's easiest for you to get. I don't think there is a right or wrong here. I think the issue is that I feel that if you do now an LP, I don't know, on Monday, and then you wait for the results, then it can take a long time. Then it's 2 weeks later and you still haven't given anything. So whatever is easier for you, if you can even give like tocilizumab on Monday, just give tocilizumab on Monday. I don't think we know enough. People have used that for treatment escalation. I think particularly in cases where there's a lot of swelling, the tocilizumab appeared to kind of maybe work a bit better. And also if there's a lot of enhancement, both Plex and tocilizumab, because tocilizumab also is important for the blood-brain barrier. So if you have anything that a lot of the things coming systemically helps sealing the blood-brain barrier. So I would really, because I think the evidence is very anecdotal, pick one of the two, which is the easiest for you to arrange. And I think you're right in a sense that if this boy will need to have plex, I can do plex on the ward, so it's very easy for me. But if you need to do plex in the intensive care, or they may feel that they need to, he's too irritable and dyskinetic, then I would go for an anti-IL-6.
Okay, ma'am. Thank you, ma'am.
All right.
And I think there's a question about the immunosuppression and the steroids. So why don't we see, once you decide on that, why don't we see about the response, and then we have another chat. You can even email me directly. We maybe do another MRI and look at it and make a decision.
Okay, thank you, ma'am. I will have.
Yeah. All right. Thanks, Ian. Anas, please update us. All right. Thanks.
Sure, sir. Sure, sir.
Okay. Next case, Pituja, quickly. I think slightly out of time. Yeah.
Good evening, everyone. We have 5.5 months old male child born to non-consanguineous parents at preterm, 34 weeks of gestation with birth weight of 2 kg. And I should stay for 10 days in view of lactic acidosis and reported to have dehydration encephalopathy. He presented at 5.5 months with developmental delay in the form of gross motor being with no neck control, not recognizing the mother, and there was excessive crying. There was also a history of sound-induced startles and multifocal jerks was present. On examination, head circumference was 37. That was microcephaly for the child. Sutural overriding was there. There was no tracking, no vision was there. Arcing of the body, dystonia kind of movements were there with paraspinal weakness, and mild spasticity was present. Rigidity was also felt. And there was also a history of feeding difficulties. The next slide.
Yeah. I don't have a slide.
Sorry.
Okay, so yeah, that's the basic clinical picture, and then I think we got an MRI done. At 5 months.
Yeah, 5.5 months. Initial investigation.
I have it after the MR. Was it done before the MR?
It was done before the MRs.
Okay, I mean, I put in the diagnosis slide.
Okay.
So, yeah, I think we can get.
Yeah, sure.
All right. Okay, on the MRI, we have on top the diffusion sequences, and on the diffusion, you can appreciate slightly asymmetrical changes in the bilateral dorsal striatum, the external capsule. The medial aspects of the basal ganglia are relatively preserved, whereas the lateral putamen, the external capsule, the thalami, especially the pulvinar thalamic nuclei, the ventrolateral thalami demonstrate restricted diffusion. Even the cerebral peduncles have some degree of foci of restricted diffusion out there. Some degree of under-localization of ciliary fissures, but the major changes are in the central regions of the brain. I would also agree that there is some degree of perimetric volume loss, because as you can see that the ventricles are reaching up to the particular regions out there, and some hyperintensities along the frontal, especially the parietal deep white matter, and possibly some asymmetry in the volumes of the white matter changes over there. The left, the frontal parietal white matter is slightly more in comparison to the right side. So some white matter volume loss and the predominant changes in the basal ganglia, lateral aspects and the thalami out there, and the ventral aspect of the midbrain. On the SAG images, slightly reduced the corpus callosum even for a 5-month-old, so has slightly hypoplastic out there. And yeah, no changes on the GRE sequences or SWS sequences. Spectroscopy was placed on the basal ganglia and also in the white matter, and you can see that demonstrates a significantly inverted lactate peak. The choline is slightly elevated, but that is to a degree normal for an infant at 5 months of age, possibly slightly elevated, but the main change is the lactate over there. So based on this picture, I think we already had a diagnosis prior to the scan. We're thinking of a mitochondrial disorder.
So at day 13 of day 3 of life, where we had lactic acidosis, and then the investigations were done. Ammonia was elevated, lactate was elevated, lactate pyruvate ratio was elevated. The lactate was done in sequential events, and even in October last year it was done. It was at a higher range of around 85. So TMS also showed significant elevation of alanine and acyl-carnitine levels. Clinical exome sequence was done that was suggestive of FOXRED1, which was a mitochondrial complex 1 deficiency. It was an autosomal recessive variant and homozygous, though uncertain significance is given, but there was a phenotypic match as it was an autosomal recessive variant. Child had microcephaly, and had cortical blindness with feeding difficulties, hypotonia, rigidity, myoclonus, seizures, and the white matter abnormalities that was seen on the MRI, along with lactic acidosis as the main features. So it was a phenotypic match for FOXRED1 mutation.
Very few cases reported for FOXRED, especially in terms of imaging. I could only find this paper published in Frontiers with a review of literature, and at least 2 of their cases were in more chronic changes. You can appreciate there is chronic encephalopathia out there. But again, if you see the lateral aspect is more common, more affected in comparison to the medial aspect of the basal ganglia, whether that is the phenotypical change or not on the MRI is to be seen, because we have only limited cases reported. So yeah, at least imaging wise, it matches the mitochondrial disorder, and I think as Pituja has outlined, that clinically also matches the gene. So if anyone has a similar experience with the gene, that would be it.
So we could also find only 2 cases that was reported, and that was back in 2019 January. That was the last case that was updated in OMIB that we could find with the mutation.
Okay, I think yeah, since limited cases are reported, I don't think we have others over here with similar experience, but so yeah, that's the FOXRED1 gene with imaging and clinical, almost a clinical match. Yeah. So, all right. If there are no further comments, I'll move on to our next case.
Okay.
Apurva, over to you. Thank you.
Yes, so this is a 14-year-old female child. This child was born out of a 3rd-degree consanguineous marriage, and she had presented with global developmental delay, motor affection more than the cognitive affection. So up to 5 years of age, she had developed walking with support, but from 5 years to 14 years of age, there was no improvement in the motor abilities, such that there was a developmental stagnation, plateauing of her motor domain. Otherwise, she was ADL independent. Also, the other complaints which were present were the increased tightening of the limbs. On examination, the child was conscious oriented, cognition was much better, no cranial nerve involvement, but there was significant spasticity of the lower limbs as compared to the upper limbs, with hyporeflexia of the limbs, and spastic dysarthria was found on examination with no cerebellar signs. So based on this, there were 2 MRIs, one that was done at 16 months of age, and this is the gait of the child, in which the child is shown to have little waddling along with impaired dorsiflexion, and the bilateral equinus is being seen. So based on the examination findings, and there were 2 MRIs, one at 16 months and one at 13 years.
16 months is slightly degraded images. I'm not sure how much you can make out, but at 16 months, we had some white matter changes, ventricular regions, deep white matter, subcortical white matter in the bilateral hemispheres. Cannot appreciate the basal ganglia thalami changes on these images. On the coronals, maybe slightly better images. We can appreciate this leukodystrophy. The cerebellar white matter and the peridentate regions demonstrated these symmetrical hyperintense changes. So these are the only, I think, changes that maybe even the brainstem over here on the coronal sequences is demonstrating some degree of hyperintensities. So these are the only 2 films I have. Yeah, of the child at 16 months of age. A follow-up at 13 years, some degree of cortical volume reduction. And now you can see there is more homogeneous white matter changes in the frontal regions, temporal regions, slightly more hyperintense in the parietal or occipital regions, but yeah, some degree of cortical volume reduction, diffuse white matter changes in supratemporal brain, cerebellar atrophy, brainstem atrophy, corpus callosum are also severely thinned out. Yeah, on the follow-up sequences, yeah, these are the progressive changes demonstrated. So the investigations, as I think Apurva you've already mentioned, or want to just summarize?
All the investigations were the basic TSH, EEG, NCS was normal. Aryl sulfatase A and B, these were the outside investigations. So based on the MRI findings and the clinical developmental plateauing, we went ahead with whole exome sequencing for genetic white matter disorders, and we found HSPD1 gene mutation. That was a hypomyelinating leukodystrophy type 4.
So yeah, so HSPD1, as per the latest classifications, comes under the leukoalcinopathies, though they really have some degree of hypomyelinating type pattern. I think the clinical matches, is that right?
Yes, sir.
Pooja,
There was spastic paraplegia was there, though there was no nystagmus, but the other features of progressive developmental plateauing with degenerative findings and spastic paraplegia with hyporeflexia being a part of peripheral neuropathies has been found in this case.
And these are the other disorders. This is from Dr. Balthazar's papers. Hypomyelination with cerebral atrophy. The common findings were the common abnormalities, other than the one which you have seen is Fourier syndrome, leukodystrophies, HAPCs, Salow's disease, folate deficiencies, and other hypomyelinic disorders in the late stage, such as multiple disease, can have some degree of cerebral atrophy. So we just wanted to highlight the findings of HPSD1 mutation, HSPD1 mutation with some degree of hypomyelination, and in the later on stage, and these brainstem and cerebellar neurodegenerative changes. So I'll open the case if anyone has any questions.
You have a genetic diagnosis. Can I just have a question to Nihaal about the imaging? Maybe I've missed it. Would you the axial on the lower row, would you say this is a hot cross band sign?
Yeah, I would. Not very clear, but yeah, there is the last two images. But as we have already, yeah, it looks like
it's not specific. Yeah,
not specific. Yeah, oligopontocerebellar degeneration, SCAs, CDGs.
Why did you raise the hot cross bun particularly, Eugen?
We had a discussion by mail some time ago with Nihaal about this finding.
Yeah, it was published by, I think, the Italian group for CDG1, but later on we found out that it's not pretty specific for that disorder. Other disorders can have the opportunities.
I think a lot depends on how hot your bun is, basically. I have a question. When the result came back as hypomyelinating leukodystrophy type 4, what does type 4
type 1 type?
No, on that slide it's type 4. What does this
type 4, sorry,
mean?
Type 4, I think, is just one more type in addition to type 3. OMIM is just listing in sequence what is being published, like PCH17, PCH18. It has no logic. It's just a enumeration like in a telephone book.
So we shouldn't be using it, no? If it's no logic, no? We should just...
Yeah.
It's not really logic. We should
just describe what it is, because I think more typing, there's so many types, no?
Yeah, and stick to the gene.
The gene and the phenotype. I think the type is actually, I was thinking the same. I'm glad. I didn't know. I'm glad that Kish mentioned it.
All right, then we'll move on to our next case, Pooja.
Yes, so this is a 2-year-old boy who was born out of a non-consanguineous marriage. This boy presented with history of developmental delay such that at 2 years of age, the boy was sitting with support, walking when held at both the hands. Cognitively, he was just babbling. Stranger anxiety was present. On examination, cognition part was better, good eye contact, fixing, tracking. But again, this child had spasticity of lower limb more than the upper limb, seizuring gait with bilateral equinus. So syndromes related to bilateral spasticity, motor more than cognitive was also considered in this case. This child also had one history of at 2 months of age, an acute event of acute onset encephalopathy. That time had metabolic acidosis, pneumonia requiring mechanical ventilation, following which the parents noticed that there had been progressive hair loss. MRI imaging of this child was done, which showed
So hair loss was at what time frame? Because we hear at
from
least it
2
was
months of
common,
age. After this, 2 months of age.
but some medication was given in between.
After that, the
the-
child was diagnosed with some
Okay,
disorder.
okay. Yeah. So some medication was given. So hence there is
Yes, sir.
regrowth of hair. Okay. All right. So we have the this was done a couple of weeks back at the age of 1, 2 years and 3 months. Some degree of cortical volume reduction, frontal lobes, temporal lobes out there, and occipital lobes. But in terms of no malformations, no signal changes. Coming down to the posterior fossa, some degree of atrophy, formation of the folial spaces. Even the brainstem structure would be slightly reduced over there in the axial sequences. So main changes are of volume loss, supratentorial volume loss, infratentorial volume loss, no malformations, no signal abnormalities, no focal lesions. I have coronal and SAT sequences. You have some degree of atrophy of the cerebellum out there on both hemispheres. I'm not sure, and so the corpus callosum also is slightly atrophic or thinned out. I'm not sure if you need to term this as hypoplasia or atrophy. I'll leave that to Eigen, but the brainstem is also definitely abnormal out there. And then based on, I think we have a genetic diagnosis as Purva has highlighted out, and Purva is what you.
Yeah, so then biotinidase levels were sent, which were low. So after that, genetic analysis was done, which was suggestive of biotinidase deficiency.
So yeah, as you mentioned, the skin changes, the hair changes in terms of biotinidase deficiency. These are the various imaging phenotypes for biotinidase deficiency, but what in the chronic stages can have some atrophy related changes. But again, white matter abnormalities can be seen, focal gray matter changes can be seen, myelopathy can be seen, and in the acute stages, diffusion changes can be seen. This is a paper recently published which highlights the various imaging features of biotinidase deficiency. The only question was the brainstem changes and cerebellar changes. For their cerebellum can be, yeah, but this is brainstem hypoplasia, or this is also part of the atrophy. If anyone has similar imaging findings, it would be helpful, or you can, or any further comments. Okay, so biotinidase deficiency also look at the brainstem and cerebellum over here, especially the brainstem can have these plastic changes. So maybe another imaging phenotype which needs to be kept in mind. All right, Prituja, I think, yeah, quickly if you can. We have, I think, second last case.
So this is another 7-month-old male child born to non-consanguineous parents with no any postnatal complications, presenting with developmental delay in form of partial neck holding and creeping only at 7 months of age. Child had no social smile, not recognizing the mother, not turning towards the sound, and no tracking was present. There was also dystonia with twisting of the body that was told by the parents. On examination, weight height was below the 3rd centile. There was microcephaly, bitemporal hallowing with retronathia was present. Cortical visual impairment was there, dystonia was present, and there was weight bearing on toes that was present. Investigations were done outside that showed CT brain that was normal, beta was done that was normal, and EEG showed diffuse slowing without any epileptiform discharges. They had also done an ophthalmology consultation that showed delayed visual maturation that was reported. MRI brain.
All right. I forgot the age of the child.
7
all right, so all right. So MRI at around, I think it was around 7 months of age. Slightly simplified gyration, not very severe, but I can appreciate, especially over here in these areas in the inferior frontal lobe, the perisylvian regions, also the parietal lobe over there. Slight simplified gyral pattern demonstrated. Yeah, also in the frontal lobes out there, if you can see that slightly broadened gyri over there, not thickened, but yeah, there is some simplified gyral pattern. Coming down inferiorly, the main change is again some degree of hypoplasia on the brainstem on the axis sequences in the pons. Also, the cerebellum on the axis appears to be reduced in volume. So yes, so these were the main changes what I could appreciate on the axis sequences. Again, coronal sequences again highlight some degree of simplified chiral pattern there in the supratemporal brain. Cerebellar hypoplasia. Again, better appreciate on these sagittal sequences. You have some degree of pontocerebellar hypoplasia out there, with some even corpus callosum is slightly reduced in volume for a 7-month-old. So pontocerebellar hypoplasia, some degree of simplified chiral pattern in the supratemporal brain. These were the main findings. And then when we think again, we go back to Eigen's paper, PCH with supratemporal abnormalities. The simplified chiral pattern has these various genes which can cause similar imaging findings. So PCH with cortical malformations, the most severely affected are the renin pathway disorders. The VLDLR and renin pathway usually have more of a septic type pattern with PCH. Both of them typically also have a elongated vermis. Our case was somewhat similar to this case, simplified chiral pattern, pontocerebellar hypoplasia in a male child. Think of a possibility of CASK disorder, and this is what we got. Though it was of uncertain significance, I think the clinical and the imaging matches. Again, from Eigen's book, CSK as an X-linked cerebral disorder. Other clue was the optic atrophy, which was there on the imaging. I haven't put up the slides, but yeah, it was there. So PCH with optic atrophy can be seen in CSK-related disorders. Hearing loss also is a common finding, but I think we don't have it in our study. So again, if you want to add anything to this, yeah.
Child was not turning towards the sound, so some form of hearing.
Okay. Some form of hearing loss also. Okay, all right. So the clinical and imaging match.
There was a phenotypic match for PCH.
Yeah. Again, anything to add, or you want me to? All right. Okay, I think we'll quickly conclude with our last case.
Yes. 6 years old child born to consanguineous parents with history of global developmental delay, infantile onset generalized epilepsy, and there was history of visual and hearing impairment. On examination, microcephaly was present. There's ataxia that was evident.
Epilepsy, was it just generalized or anything particular?
It was mentioned infantile onset epilepsy, and generalized seizures were predominant.
All right. So I think also done pretty recently. Supratentorally, some degree of particle reduction. This would be frontoparietal lesions out there, but nothing in terms of particle malformation, no signal abnormalities, no focal lesions, no myelination related abnormalities. The main changes were in the posterior fossa of the cerebellum. There was cerebellar atrophy. Along with the cerebellar atrophy, you see the flare signals. The cerebellar cortex is also hyperintense. So cerebellar atrophy with flare, hyperintense cerebellar cortex. Supratentorally, nothing significant other than some degree of volume reduction in the cortical region out there. Again, you can appreciate the cerebellar atrophy in relation to the supratentoral structures. Again, significant volume loss seen in the bilateral hemispheres. Also, the vermis folia is again widened out there. Again, you want to say something? I'll just see you raise your hand. Okay. Okay, on SWS sequences, nothing on the susceptibility weighted images. My apologies, these were of the previous case. As you can see, optic atrophy was there. I think this put it up on the wrong. So based on that, we looked at differentials again from papers from Eigen. Cerebellar cortex hyperintensities with cerebellar atrophy. These are beta list of disorders. The list is growing as we move forward, but none of them were there in the final diagnosis. And this is what the final diagnosis was with that.
The final, genetic report, whole exome and whole mitochondrial genome sequencing was done. That was suggestive of TBC1D224 variant. It was a homozygous autosomal recessive pattern involving 3 diseases: developmental and epileptic encephalopathy with familial infantile myoclonic epilepsy, with Rolandic epilepsy, with paroxysmal exercise-induced dystonia, and Reiter's cramp was present, and this was a pathogenic variant. And MRI findings were suggestive in these cases with the progressive cerebral atrophy and delayed biliation. So it was a phenotypic match for all three variants.
Yeah, then we looked at published the ones which are published had cerebellar atrophy as a common finding. Superattentively had some variability, but yeah, the posterior fossa findings has cerebellar atrophy. Also, if you appreciate all these cases over here, had also cerebellar cortex hyperintensity on the phase sequences. So that was another imaging match. The only thing was the review literature which they published in the at least five cases had epilepsia partialis continua. I don't think our case had at the moment. But cerebellar atrophies and hyperintensity to signal changes were seen, which is an imaging match. Yeah, so if anyone has seen this, encountered this gene before, or imaging and clinical findings. All right, so that's a new gene for all of us then. So to be kept in mind, infantile onset epilepsy with TBCD1, TBCD 1, 2, 3, 4, 5, 6, whatever the mutation. Cerebellar atrophy with cortex hyperintensity needs to be kept in mind with infantile onset epilepsy as if. So yeah, that's our last case. And thank you everyone for your attention and your time. I think, apology, we slightly went over time this session. We request the present kindly submit your cases by 18th of October. We will not be taking any cases after the 18th of October. So till then, see you again and hope you have a good weekend.